Now, without further ado, we have our North Carolina Community College Oncology Lecture, Oncology Nutrition, with Jennifer Spring. And we'll give a little virtual elbow bump there since we're not doing handshakes right now. Let's take a look. I want to show you the poll everywhere question, and then we'll give you a chance to answer it and see how you did in just a moment. But the first question, a dietitian can help oncology patients with more than just discussing which vegetables and fruits to eat. Now, I think this might be kind of a softball, but we'll true or false, we'll let you figure that out, and then we'll come back to that in a minute. So, Jennifer Spring, RD, CSO, LDN, we'll talk about those letters in a minute. But you are an oncology dietitian, and you're serving as an oncology dietitian in the outpatient oncology nutrition program at the NC Cancer Hospital in Chapel Hill. And in this role, you work with patients to develop individualized eating plans to meet specific needs or concerns related to cancer prevention, treatment, and recovery. And 2016 UNC Oncology Excellent Award recipient.
Thank you.
All right. So tell us about those letters, RD, CSO, LDN. What are those all about?
So the RD stands for Registered Dietitian. That's a national registration. All dietitians need to be registered. The CSO stands for Certified Specialist in Oncology, and that's for Oncology Nutrition, and that's a certification that you get after working in the oncology environment for greater than 2,000 hours, and you have to apply and take an exam for that. So it's a certification, and you have to renew that in order to be able to continue to keep those certifications. So every 5 years you have to take a test.
Okay.
And then the LDN is Licensed Dietitian Nutritionist, and that is a state licensure. So this is for North Carolina, and every state has a licensing board that licenses for dietitians. So I'm not really a nutritionist, I'm a dietitian, I'm registered and I'm licensed.
Great.
Yeah.
And in case our audience didn't know, we have a little bit of an agenda here, which is that we hope that they will be giving serious consideration to careers in oncology as they watch this lecture and other lectures in this series. And to that end, maybe you can take just a minute to let the students here know what your career trajectory has been, how, at what point you said, hey, that might be what I want to do for a living, and how did you get there?
I was a non-traditional student, so I think maybe some of you in your current situation may have similar experiences. But I did have an undergraduate degree in history and worked for more than almost 10 years before I even became a dietitian, and my degree was not a science degree. And so I went back to school in my 30s and took one science class at a time to become a dietitian. So I built up to taking those classes and building my confidence in science. And then I went to school and did a nutrition degree, another 4-year degree, to become a dietitian. And so I came to it late in my career because I had a passion for food and health, and I had the history of cancer in my family. So I don't know, I found myself here and I absolutely love it.
Good for you. We're glad that you did, and let's take a look at that poll everywhere question. So
yay.
It looks like people, I'm going to guess, you're the expert, but I'm going to guess that they're doing all right so far.
I think they're doing great, and
Good.
We gave the answer away in my description of what I do for a living. I do more of that. But I love talking about fruits and vegetables too.
Good. So, great job, everyone, on that first question. They'll get a little bit harder than that, but they're all anonymous. So please, take a risk. Put your best guess down, even if you're not sure of the answer in future questions. And with that, Nutrition in Cancer Patients Makes a Difference, presented by Jennifer Spring.
Oh, that's right.
And I'll pass that over to you. There, you can just use the arrows to advance, and then if you want to use the mouse for the cursor, you're welcome to use that to point things out.
To point some things out.
Right.
So, let's get started. So today, I really want to be able to explain to you about cancer-related anorexia and then also cachexia, and the significance of unintentional weight loss. And we're also going to take a look at the specific nutrition interventions that I, as a dietitian, practice every day in dealing with anorexia and weight loss. And then we're going to identify some tools that we use as indicators to determine malnutrition risk, and then some of the nutrition interventions. So we should be able to answer some questions related to that along the way. So just as an statement to begin with, unintended weight loss and anorexia in patients with cancer are associated with decreased performance status, reduced response and tolerance to treatment, which may cause them to have to be hospitalized, decreased survival, and a reduced quality of life. So let's look at anorexia. What is anorexia? A lot of you might hear the word anorexia and immediately think of teen girl, anorexia nervosa. This is not what we're talking about. Anorexia at its base is just a loss of appetite or an inability to eat, or a loss of appetite for food, and that would be a medical condition. And so we're looking at this as a medical condition during the trajectory of a cancer patient's diagnosis, treatment, and recovery. We're looking at a loss of appetite specific to this type of disease. And anorexia is not interchangeable with cachexia. And we'll talk more about cachexia as we go through this presentation, so you'll be able to hopefully distinguish the two. So let's take a look. What's going on with anorexia? What's going on with this loss of appetite in a cancer patient? So there's more than a few things. Sometimes a cancer patient may come in with a diagnosis and they already don't feel good, and just from the stress of the diagnosis, that can cause a loss of appetite. But there's something else that's going on. The tumor itself is actually generating some of this loss of appetite, and part of it is because of this inflammatory response. And so what's happening here, I'm going to maybe use my cursor a little bit, and we're going to take a look. So this tumor is having a response. Let me see, here it is. Okay. So we've got this tumor that's been diagnosed, and it's going to play a role in terms of igniting some hormones that are going to kick in this inflammatory response, and that inflammatory response is then going to cause some of the anorexia. Then we also have treatments like chemotherapy. Chemotherapy is going to have effects on the central nervous system. It's going to possibly cause nausea. There may be some vomiting, there may be soreness in the mouth, abdominal cramping, things that are going to keep you from not wanting to eat. You may not be able to digest foods the same. You may not be able to, you may have tumor burden in your anatomy, in the GI tract, that doesn't allow you to feel good. There may be constipation, there may be diarrhea. So there's a lot of different things that are playing a role in this loss of appetite. So you've got the tumor burden that's turning on all these responses, this inflammatory response, and then you have the outside effects from the chemotherapy and radiation or whatever the treatment course is. So anorexia is typically present in about 15 to 25% of all cancer patients. And part of this is related to that tumor effect, but a lot of it has to do with the treatment for the particular type of cancer. And so some of the side effects or the cause of nausea are that to anorexia are nausea and vomiting, early satiety, meaning they feel full very easily, taste changes, maybe they have a metallic taste or a bitter taste from the chemotherapy, or if they have sores in their mouth or breakdown of tissue matter, they taste some of that. They may have sensitivity to smells that triggers nausea. There may be a dry mouth. If they don't have enough saliva, then it's hard for them to move foods around through their mouth or swallow them. They may have problems with digestion in terms of constipation and diarrhea. Those could be medication related, they could be chemo related, they could be related to stress and anatomy changes from surgery if they had any GI surgeries. They could have mouth sores, dysphagia, difficulty swallowing because of maybe tumor burden or from the mucositis or the pain. There's a lot of anxiety associated with the cancer diagnosis, with the stress of having to figure out the treatment course and how to be able to manage work and home and all of those types of things. There's depression. And then fatigue. Fatigue is probably the #1 side effect to cancer treatment. And then we mentioned medications also can play a role in decreasing appetite and not wanting to eat. So in this one study of 191 individuals of mixed different types of cancers, the symptom burden, all those symptoms that we were mentioning, the nausea, the loss of appetite, the constipation, the diarrhea, all those symptoms, the symptom burden for those individuals is actually a predictor of nutritional risk. So the more symptoms that an individual has, the greater their nutritional risk, right? See how this goes up here? So 0 symptoms, not as high nutritional risk. 1 to 2, maybe they just have fatigue and nausea. Maybe they have fatigue, nausea, and taste changes. And then maybe they have all of them, which might be the case for some of the patients that I see. I see a lot of head and neck cancer patients. They are going to run the gamut of having more than 3 symptoms during treatment, and they're going to be at very high nutritional risk as a result. I love this cursor. So as a dietitian, the challenges of dealing with loss of appetite with anorexia are great. They really are, because there's so many aspects to the reasons why an individual is not eating. And so I have to be creative, I have to be very patient, I have to work with where the patient is at that moment, I have to be consistent, persistent, I have to create a sense of repetition. We need to maybe consider this a new job, dealing with loss of appetite. The individuals have to take on a new role. They can't control maybe their cancer diagnosis. They can't control maybe their treatment other than not coming or going. But they can be diligent about taking care of their nutritional needs. And then I have to be their advocate. And I'm their advocate for themselves. I'm their advocate to their family members. I'm their advocate to their care team here. Their medical care team. I'm the one who's going to, let people know that it's okay that your mom is not eating large meals. It's okay that she eats small, frequent meals. You don't have to push her to eat, those kind of things. So I'm going to be their advocate. And definitely making sure to involve family, caregivers, friends, people who are looking out, and have them be part of that care plan. It's important. So this looks like a very complicated page, and there's a lot on it. I want to tell you, calculating the needs, the calorie and protein needs of patients it could be tricky. And as a dietitian, I've been doing this a long time. What I like to think of in terms of these needs is we don't have to be so precise. I'm using these needs to calculate what I think that individual might need in terms of calories and protein during treatment and after treatment, and then I'm calculating what they're taking in on a daily basis or a weekly basis, and I'm figuring it out, and I'm balancing those and comparing, contrasting them. And so these don't have to be precise, but we do have some guidelines in terms of my practice. And so in terms of calculating calories, we have some we can either go by calories per kilogram. That seems to be a very standard way of calculating calories. The calorie needs for a patient who has cancer are basically the same as the calorie needs for a healthy individual. We may use some calculations in terms of looking at resting energy. We may use something called indirect calorimetry. It's not done in the outpatient setting. It's very expensive, and they usually do that in an inpatient setting. And that talks about how much energy is coming off of an individual when they're at rest, and they do a test to see what they're burning at rest, and then you can calculate up from there. So these predictive equations need to take into account whether the patient is healthy, whether they're ill, whether they're critically ill, and we'll adjust that accordingly. And I use a combination of the predictive equations, like the Mifflin-St. Jean, and also the calories per kilogram. So I use a combination of everything. There's not one perfect way, but there are better ways. And so these are the ones that are better, 25 to 30 kilocalories, or using a predictive equation in terms of cancer, we like to use Mifflin-St. Jean. And then in terms of calculating protein needs, healthy individuals, we're going to be calculating these very similarly. Healthy individuals need about 0.8 grams per kilogram. And then if a patient or if an individual is, let's say that they're working out or they play sports or they're a weightlifter, that means that they're catabolic, they're breaking down and building up muscle mass. So we want to do a little bit higher on the protein needs. And for those individuals that are metabolically stressed, for somebody that might be in an ICU unit, they might have even greater needs. But for our cancer patients in general, it's a rather wide range. And again, I'm calculating it based on those independent factors, whether they're healthy, they're acutely ill, whether they're physically active, how old are they, what is their treatment. I'm going to change that based on a lot of different factors. And so for cancer patients in general, we are looking at 1.0 to 1.5 grams per kilogram per day of actual weight. And we have some different targets or some different numbers for individuals that are obese or severely obese. We take all of those into consideration. So there's a lot going on here on this page. And the more that you practice in this field as a dietitian and the more you work with patients and understand what they're going through, you can kind of figure out ranges that work best for you. So we talked about anorexia being the loss of appetite, loss of an appetite for food. Now I want to talk about cachexia. They sound so similar, don't they? So cachexia is actually the presence of significant weight loss, or sarcopenia. And sarcopenia is actually what we call, it's when the muscle mass depletes. So you have severe depletion in muscle mass. And so cachexia is the presence of significant weight loss or sarcopenia in the absence of simple starvation. So it's more than just not getting enough calories. It's beyond that. This is that tumor effect, the inflammatory response that's kicking in, and it's not just about not eating. It's gone beyond that. So it's a progression of a wasting syndrome characterized by weakness, significant and severe weight loss, including fat and muscle, and it usually is tumor-related, related to that inflammatory response. And so when we're looking at individuals and I'm asking them, have you had weight loss, or I'm calculating their weight loss is greater than 5% over the past 6 months, or if they have a body mass index that's less than 20 kilograms per meter squared, or a degree of weight loss greater than 2%. Or if they have sarcopenia and any degree of weight loss. These are all ways that we can define cachexia. That's that severe wasting. And so therefore, cachexia is not the same thing as anorexia. Anorexia is actually one of the factors leading into cachexia. So they're not interchangeable. Oops. Let's take a look at the physiology of cachexia. So again, this is that tumor response. It's a deranged metabolic state. The hormones in the system are abnormal, and it occurs in addition to that loss of appetite, but not always. Loss of appetite is not the only condition. If you have been diagnosed with cachexia, nutritional repletion, just getting calories and protein alone are not going to be able to cure that. There's a lot more going on. You have to maybe deal with the inflammatory response. So it's the brain, it's the tumors acting on the brain, it's these inflammatory elements, the cytokines. You're not producing the fat cells. This next slide that I have is going to talk about it a little bit more. So hallmarks, these are hallmark signs of cachexia. If we really are diagnosing an individual that has gone beyond just loss of appetite and mild weight loss, now we're looking at insulin resistance. So when you have insulin resistance, you're not absorbing your nutrients appropriately, your carbohydrates. You might have high blood sugar levels, you might have high fat levels, hyperlipidemia. There may be a failure to utilize glucose and free fatty acids for energy, so you're breaking down muscle mass. Lean body mass is the primary source of your energy because you're not utilizing those other sources of fuel. And you have an increased metabolism because as infants, when we're born, we have something called brown fat. And that brown fat is very metabolic. It has a lot of activity. It burns energy. And it's a way that we survive. And so as we age, we get more and more white fat, and that's the type of fat that we have as adults. And that white fat is not as metabolic in terms of burning energy. So when this cachexia kicks in, we start to get a conversion of our fat cells, our white fat cells, to this brown fat cells. And so that creates an even more metabolic, catabolic environment where we're breaking down more fat cells and we're utilizing this muscle mass as our energy stores. You know, when I'm seeing patients, sometimes I'll tell them, oh, is it time for my poll? Let me go back, one more. Sorry.
No problem.
When I'm seeing my patients, one of the things that I might ask them is, or I might tell them just to get, you know, this is at the early stages when I'm first meeting them, and I don't want them to get to this point of cachexia, but I'll tell them, you know, if you're losing more than 2% of your weight per week, if I'm seeing them on a weekly basis, greater than 2% of their body weight per week could mean that some of that weight loss that they're having is actually coming up to 50% of that weight loss could be coming from their muscle mass. And it's so important just that they don't start losing that muscle mass early on because of the fatigue or the inability to maybe swallow if it's a head and neck cancer patient. So I really try to emphasize that at the outset. Okay, now.
All right. So here's our next poll question. Anorexia is defined as a loss of appetite and inability to eat. The term is interchangeable with cachexia. And so go ahead, and again, if you want to make a guess on this, that's fine. It's anonymous, but I think if you've been listening carefully to Jennifer, you're going to get this, and it looks like they already are. But we'll leave about 10 more seconds for anyone who hasn't had a chance to answer yet to go ahead and do this.
All right.
I think we're staying with a trend here. So how did they do?
They did great.
Good. We have a smart audience.
We have a smart audience. Well. So anorexia is a loss of appetite and inability to eat, but it is not interchangeable with cachexia. They're two separate items.
Great.
So we want to keep those separate.
Just a reminder to our audience, you will have a chance to ask Jennifer your questions at the end. So be thinking of those, maybe jotting those down on a piece of paper, and then at the end of the lecture, you'll be able to share those with Jennifer and poll everywhere.
Thank you. Oh, okay, sorry. So, sorry. So here we have our slide. So we talked about anorexia and cachexia, and so the anorexia is sort of leading in, or a component of cachexia, and this is leading to this progressive skeletal muscle loss. That's your lean body mass without loss of fat mass, with or without loss of fat mass. And it just continues to cause impairment of function of individuals that are undergoing treatment and or in recovery. So weight loss is that major component. And that's the sarcopenia, the loss of lean body mass. So lean body mass is every other type of mass tissue in your body. It's everything but the fat mass. So it's the muscle, the skeletal muscles, the smooth muscles involved in breathing and digesting your food, those small muscles that are involved in the swallowing. We have all these muscles that are involved in swallowing that we don't even think about. The skin, the mucous membranes, the blood cells, connective tissue, all of these are incorporated into lean body mass. And so when you're having depletion of that lean body mass, The more depletion that you have, the more it increases morbidity. So just as we looked at the number of symptoms increasing nutritional risk, we know that the lean body mass depletion, the more body mass depletion an individual has, this is a predictor of survival. And so this great study that was done looked at two models. It looked at the conventional model where we were looking at tumor types, stage of cancer, the age, and their performance status, and that, what was that, how did that predict survival in terms of our cancer patients. And then they also looked at nutrition covariance, the body mass index, weight loss, unintentional, intentional weight loss, and then the lean body mass. And what was found was that the nutrition model was a greater predictor, using that lean body mass depletion was actually a greater predictor of survival than the conventional variants, so the tumor type, just the cancer alone. So regardless of their baseline body mass index, any time that they had weight and muscle losses that were significant to severe, any incremental losses can decrease survival. Nutrition definitely matters. I'll keep talking. So intentional weight loss, we're going to talk about unintentional weight loss, but intentional weight loss is when we are inducing intentional calorie deficit, if we're trying to reduce our calorie intake for weight loss or for specific reasons. And our bodies tend to adapt to that over time. And the fat losses when we're doing intentional weight loss are usually fat mass losses and not necessarily muscle losses, hopefully not muscle losses. But unintentional weight loss, this is induced by a combination of loss of calorie intake and then that inflammatory response that's triggered by the tumor and working on the brain. And this is where you're no longer losing the fat mass, you're actually switching from lean body mass and fat mass for the energy to predominantly fat. This doesn't occur, so it's mostly that lean body mass, tissue, blood, muscle that's being depleted and not the fat mass. In this study that was done in 2007, they looked at 17 individuals with head and neck cancer. And they did some tests and they showed that individuals after a 9-week period of time through treatment, which is pretty standard, that the weight loss started immediately. And I see this too because this is my predominant cancer population that I work with. Within the first 1 to 2 weeks of treatment, because of that loss of appetite, taste changes, or difficulty swallowing because of pain or dysphagia, there's weight loss immediately. And then the average total loss was about 15 pounds per, or about 1.7 per week, so 15 pounds total. And that lean body mass accounted for about 71% of that loss, so greater than 50% was due to lean body masses. So you're getting, you know, beyond just weight loss, you're getting into that cachectic phase. All right, and I just want to point out, I don't remember if I have it on one of these slides, I just also wanted to point out that even though an individual may be obese, we need to take that into consideration. So you can still have lean body mass losses when your percentage of weight loss is greater than that 2% per week, greater than 5% in a month, or greater than 10%, I think it is. I have to look at my cheat notes here, greater than 10% in 6 months. So that's severe weight loss. And so even for an individual that may be obese and that individual might say, oh, I've got room to lose weight, I really emphasize again the lean body mass losses even if they're overweight, and we need to prevent those severe weight changes from week to week. So here's a little bit of what I do. Beyond calculating their needs and trying to compare and contrast what they're taking in on a daily basis and making sure that it meets their needs and that they're not losing weight. Some of the dietary interventions, definitely, I'm we're constantly coaching, being the cheerleader, giving encouragement, being that advocate. It's really important to let them know that you're on their side so that they can trust the plans that you have made for them. And then I'm dealing with strategies for managing the taste changes and the smell changes. Talking to them about, maybe the presentation of the food on a pretty plate, even though it's not a lot of food, if it looks better, you may be more inclined to eat it if you have loss of appetite. The atmosphere, are you just sitting in front of the television and not paying attention? Are you sitting in a sunny room? Are you eating with other people? So these are all parts that are going to play a role in allowing that individual to have a better plan in place to overcome that loss of appetite. Family dynamics is a big one. I want to point that out. So working with individuals, family members, spouses, want to show their way that they can contribute or love their loved one. And so food seems to become a big issue. Eating is a big issue. It's one thing they can control and manage. And so there has to be a connection. You have to make sure that everybody in that family is understanding that it's okay not to eat at certain times. It's okay to eat small amounts. It's okay if you can only drink supplement drinks, and make sure they really understand that and that they're not pushing too hard, because that can throw somebody off for the whole day if they're being forced to do something. Honoring patient preferences. So coming from a dietitian, yes, I do like to talk about fruits and vegetables and the plant-based diet. I think it's important. But at some point, I even have to loosen the straps and I have to say it's okay to drink McDonald's milkshake 3 times a day if that's going to allow you to get some calories and protein, because that's what you're able to do. And so you honor those preferences, you build that rapport, you continue to be their advocate. And then nutritional supplements, and nutritional supplements that I'm speaking of here are things like commercial ready-to-drink protein shakes like Orgain and Ensure and Boost, Carnation Instant Breakfast Powder. There's so many out there, so there's a lot to choose from. And then also enteral nutrition. Enteral nutrition meaning that they might have to have a gastric tube placed or a nasogastric tube to help support intake, because they're not able to, whether it's a pain issue or if it's a physical issue. We have to be able to provide guidance and let them know how to do their gastric tube feedings, their tube feedings. These are sort of kind of gold standard older studies done in 2005, and they were looking at head and neck cancer patients. And why does nutrition matter? This is really important. This is why does nutrition matter for these patients? So these are individuals that are going through that 7 to 9 week treatment. In this case, they were looking at patients that were doing radiation therapy only. And what they did was that they looked at 3 different types of interventions. Here's my cursor. So the intervention with the diamonds, which is right up here, that's the nutrition counseling. That's where the dietitian comes in and talks to the patient individually on a regular basis, maybe every 7 to 10 days during that treatment course. And then some of the patients only took the protein supplement drinks like the Ensures and the Boost. And then some individuals didn't get any type of intervention, nothing. And so what this is looking at is that those individuals that had nutrition counseling with a dietitian actually did great through treatment, right? Through the intervention phase right here. And then after treatment, for 3 months after, actually sustained the good caloric energy intake beyond that for 3 months. Those that did the protein shakes alone, they did well through treatment, but as soon as they weren't in contact with the dietitian anymore, it started to drop off and they started to go under. And then those that didn't have any interventions didn't do well in general. They never really seemed to come back to their set point, their baseline. And the same is true for just protein intake in general. The same exact concept. So with those that had nutritional counseling, which I believe is the diamond, did well through treatment, and beyond 3 months they were stable for 3 months beyond. And those that took the protein supplement shakes did great with their protein intake during treatment, but dropped significantly after treatment. and then those with no intervention, you see the same curve here. So nutrition intervention, working with the dietitian, is really important because we want to catch that loss of appetite early on, and then we want to make sure that we're encouraging, giving good education, good information to follow through after they finish treatment and through recovery, because sometimes we don't always get to have the follow-up if they don't live close by. So we want to make sure we're giving them as much information as possible, and then having a little bit more for them to work with after they've left our care. So some of the non-dietary interventions, let's take a look at those. So these are not necessarily these are not the meal planning and the supplement shakes. These are additional sort of outside factors. There's different psychosocial aspects that can interfere with the patient's loss of appetite, or it can cause loss of appetite, and so things that can be done outside of working with the dietitian to deal with anxiety or depression and family and spiritual distress. So maybe they need to have some kind of counseling, or they may need to take antidepressant. Those might help with that loss of appetite. There are different types of medications or drugs that they can take, the progestational agents, like Megace or Megastrol. What this one does is it helps to, these actually, and the corticosteroids, these two right here, they actually help to increase the appetite, and they do allow individuals to gain weight, but the problem is that it's not necessarily lean mass that they're gaining. A lot of times there's fluid weight gains with these two agents, so it may not be the best choice for an individual that has cachexia, because they are possibly just going to gain some fluid weight and it may not work. We're seeing more use with the cannabinoids, so the TCHs. We've been using dronabinol, which is the non-stimulant type of cannabinoid. And what these do is help to alleviate some of the nausea that may be associated with treatment. They also can be appetite stimulants. We still don't have a lot of safe information about this, and it's definitely one that we wouldn't use in the elderly population because it may affect some of the psychological aspects of aging, so we don't want to use that. We have prokinetic agents and proton pump inhibitors. These are dealing with the GI tract. Prokinetic agents are like Reglan. It helps to move things through the system. It's a GI motility agent. It moves things through so that if an individual feels full, they can help to empty their stomach, so then they may not have a early satiety. And then the proton pump inhibitors deal with esophageal reflux. So if they're having acid reflux, if you temper that down, maybe it'll make it easier for them to eat. Some non-steroidal, non-steroidal anti-inflammatories may help with that inflammatory process, to help, to make it easier for them to not become cachectic. There's some research that looks at using some nutritional vitamins and omega-3 fatty acids. These would be omega-3 fatty acid would maybe work on that inflammatory response. It may be better utilized in conjunction with some of the other pharmaceutical agents, amino acids. So we've got the HMB, which is a chemical that is produced when the body breaks down leucine. They did some research that looked at HMB, glutamine, and arginine to see if that would help with that inflammatory response, but it didn't really show. I think they looked at 472 patients with advanced lung cancer who would be at risk for the cachexia. But there was no statistical significance in the 8 weeks in terms of lean body mass accumulation, and so we're not 100% sure that these are beneficial at this time. Exercise is one that's completely underutilized, if you're not using your muscles in motion, if you're not using them in activities of daily living, they become diminished. And so light activity during treatment is, if an individual is able, we really encourage that so that they can continue to maintain those lean body mass stores. But a lot of times we don't really think of that. So one of the keys that I mentioned at the beginning of a cancer treatment to a patient is make sure that you're moving every day. It doesn't have to be an exercise program, but try to move as much as possible.
All right, and here we've got our next poll question. So, dietary interventions for anorexia and cachexia that help to put a brake on unintentional weight loss include, and we've got 4 choices. So, A, eating small, frequent meals and snacks. B, managing taste changes. C, use of nutritional supplements. Or D, all of the answers. So, go ahead and pick A, B, C, or D. Whichever one you feel is the best choice. And we'll take about 5 more seconds, let folks are really ready for this, so that's great. How are they doing, Jennifer?
They're doing great.
Good, good.
They're doing so great. Am I ready to answer the question? Are we a few minutes more?
No, I think we're good.
Okay, it's correct. It's all of the above.
Great. So thank you for paying attention and getting that one. And we'll go to the next slide.
Okay. So, in our field of dietetics, in the oncology field, one of the things that we do every day is what we call a malnutrition screening. It's looking for those risk factors that can put somebody at risk for unintentional weight loss and lead to cachexia and sarcopenia. And so we have some tools that have been created, some better than others, that are used to find out if patients are at risk for malnutrition. And so we have the patient-generated subjective global assessment, the malnutrition screening tool, the malnutrition screening tool for cancer patients, an international one created, it's called the Malnutrition Universal Screening Tool. These are all valid, they're specific, and they're mostly quick and easy to use. And so the next slide here is going to just kind of break it down a little bit. I just realized in my slide at the PG SGA, the Subjective Global Assessment, actually has about 17 items, I think it is. I don't think it's 7, that are looked at. So it's a lot longer. You can use it in the inpatient and the outpatient environment. Usually an individual has to have this conducted by the nurse with the patient directly. Although the patient could answer the questions, and then they have to score it. Each of these has to be scored at the end. And the suggestive global assessment also involves a physical assessment. Then there's the malnutrition screening tool, the MST, can be used for both inpatient and outpatient, and this looks at that weight loss. How much weight have you lost? How much weight have you lost? Are you eating less than you normally would? Do you have a poor appetite? Do you have anorexia? We don't usually use the word anorexia to our patients. We usually ask them, do you have a poor appetite? And then those are scored. Then you have the malnutrition screening tool for cancer patients, asks a little bit more details. What are the changes in your intake of food from when you first started to this week or when you finished treatment? Looks at the weight loss. It looks at body mass index. And then it also looks at the Eastern Cooperative Oncology Group performance measure. And this is looking at your physical abilities. And I didn't put it on the slide here, so I'll look at it. So you score on the ECOG based on your ability to be physically active. So if you're fully active, you have a 0. If you're light and you're sedentary in nature, you get a 1. If you're moving and able to do your own self-care, then you'll get a 3, and so on. And so you get these scores based on where are you in terms of your ability to be active during your daily life. So of all of these, probably the most validated screening tool for cancer patients is the malnutrition screening tool, the MST, with the 2 questions that it asks. Have you lost weight? How much weight have you lost? That's kind of combined. And then, do you have a loss of appetite? Are you eating your regular diet? Those two questions alone can tell me a lot about whether you're at nutrition risk. I use them at every consult. Okay, so nutrition, focusing on nutrition from the outset, we've learned that right at the very beginning, looking at that one study, right at the very beginning of treatment, individuals can start having a loss of appetite and they can start losing weight. And the loss of just 5% of your baseline weight can shorten survival. So it's really important to intervene often, to intervene early, to identify those changes, to identify what it is that's causing the anorexia, see if you can make a plan that would allow an individual to turn it around and keep it at bay, to keep those losses lower than the 1 to 2% per week. I think one of the key things that I read is this percentage here. It's estimated that the deaths of 10 to 20% of patients with cancer can be contributed to malnutrition rather than the malignancy itself. So you can have an individual, I'll use as an example, I keep using my head and neck patients as an example, but they're great examples. You can have a patient that can make it all the way through treatment. They will have made it to that last day. They didn't get a gastric tube placed because they were going to do everything by mouth even though it was so painful. But they also had that 15-pound weight loss, and then 2-3 weeks after treatment, they've continued to have that weight loss, and now they've been hospitalized. And it's not because of their cancer, it's because of their malnutrition. So we need to take care of it early on and make sure that they're not losing weight. And in terms of managing their nutritional needs, managing it through treatment, and then just a little bit beyond. Is it just for a few days? Is it weeks? Is it months? How long do we need to be assisting these individuals through their treatment and recovery to help them to not have unintentional weight loss? So using those screening tools early and having early nutrition intervention are absolutely vital in terms of components of patient care. Many of our cancer patients that have weight loss and are at risk for malnutrition at diagnosis, and then if we're not having interventions, then that can progress, and you have exacerbated malnutrition because of the disease and the tumor inflammatory response, and then you can get further progression, and then that leads to that cachexia, which is that vicious cycle where it's very hard to turn that around, and it may involve nutrition elements of intervention, it may involve pharmaceutical interventions, it may involve more treatment if it's still cancer-driven cachexia.
All right, so our last poll everywhere question, and then we'll turn it over to our audience to ask their questions. The malnutrition screening tool, MST, has been shown to be valid and reliable for identifying malnutrition risk in adult oncology patients in the ambulatory outpatient setting. So true or false on that? And we've got a little bit of variation there, but lots of the percentages show me that we've got a lot of people in our audience answering the question. Thank you so much.
Wow.
So a few more seconds. How did they do?
They did very well. Yes, the answer is true. Malnutrition screening tool, those two questions are a great way to find out about a patient's potential risk factors for malnutrition.
Great. All right, I'm going to take this back, and I'm going to jump forward one because remember I said I'd remind you, and I am going to remind you right now, please don't go anywhere before you've taken care of the evaluation, and that's unccn.org/eval, and I'll come back to that one more time. Now let's go back here and let's see what questions you have. So we'll go ahead, and this has been a little finicky lately, so bear with me. I'm just going to go ahead and it's been not wanting to show our questions lately, so let me try this and see if I can get this to activate the slide yet. No, it's trying. This is the one where we should be able to see your questions, and should have it in just a minute there. Okay, there we go. Good. So go ahead and share your questions with Jennifer, and then we'll talk about those. And while we're waiting for those, what are some of the emerging trends? What should we be on the lookout for related to nutrition and cancer? and I guess that's it, is there anything that as you look and say, gosh, I know there's some research on this and people are exploring, this around this topic or that topic. Is there anything that you're really looking forward to seeing some more conclusive research related to this?
So we look at the American Institute of Cancer Research guidelines for healthy lifestyle, dietary action, practice in terms of giving guidance to being cancer-free, being free from recurrence in the future. And this is not necessarily a nutrition component, but I think exercise is going to be part of how do we recover and how do we prevent recurrence. Exercise is a really big component of moving forward during and after you've been treated, how that plays a role in terms of preventing recurrence.
It's a
huge.
Big deal. If you're interested, for our audience, there's some great lectures in our library. Dr. Bottiglini, Dr. Wood have talked about exercise and cancer, and it's not about, as a cancer patient, just sitting around taking it easy no matter how bad you feel. It's that getting moving. It's that getting exercise under a clinician's guidance.
Yeah.
So we do have questions coming in. Do bodybuilders, a lot of the lean body mass with cancer tend to last longer in comparison with most others?
No.
Intriguing question.
That's a really great question. I had a patient that was a bodybuilder and a trainer at one of our YMCA's, and he was, really built up before he came in to treatment, and he was so concerned that he would lose those lean body masses. So he was an oral head and neck cancer patient undergoing chemotherapy and radiation, which is a very debilitating treatment, and he had huge muscle losses during treatment. As a result, he had very low fat mass, to begin with, had very high lean body mass, but he had huge muscle losses. And his weight diminished, probably greater than 15 pounds very early on. And we came up with some very high calorie, high protein shakes that he could try and utilize through treatment. And then I believe that he also got a gastric tube placed. But then he came back for follow-up. And the wonderful thing about individuals that do physical activity or that are bodybuilders, there's muscle memory. And so if they can get back into that physical activity once they've been given clearance to be out in public and doing that again, you can regain those lost lean body mass stores. It is possible. He came back and he actually looked fitter than he did before, if that's even possible. And so I think you will have losses, but you can regain them.
Great. We're getting a ton of questions. I've just got a couple up, and then I'll put up more as we go along.
Okay.
So, but thank you so much for all the questions. All right, so what nutritional aspects do you suggest in preventing cancer in healthy patients?
Oh, that's a big question. So again, I'm going to go back to the American Institute of Cancer Research guidelines. You can find those online. There are about 10 different guidelines for lifestyle nutrition. Most of them are about nutrition. And that would be I can't go through all of them, but eating a plant-based diet, meaning more of your foods, more than 75% of the foods that you're eating are coming from the plant world. diminishing or decreasing your intake of red meats and processed meats, decreasing intake of fast foods, decreasing intake of sugary beverages, increasing physical activity. Can't emphasize that enough. But go to the American Institute of Cancer Research for those guidelines. They're the guidelines for healthy lifestyle in general, the guidelines for preventing cancer, the guidelines during cancer, if you can manage to eat that way during cancer, if side effects aren't affecting your oral intake, and the guidelines for recovering and preventing recurrence in the future.
All right. Not everything is loading up on the screen here, but we have several more questions. The next one, let's see. What career paths are open to those interested in nutritional care related to oncology? Great question.
Okay, so what I'm doing right now would be an oncology dietitian working in an outpatient setting. I work only with clinics, with patients that come to the outpatient clinics. I do not work with any hospitalized patients. So there's those two sides. You can work in the outpatient setting or the inpatient setting. There are dietitians that do research. That question that you asked me about what's the latest and greatest moving forward. So research dietitian. There's a dietitian that I work with right now that she's a research dietitian. She works with one of our breast cancer doctors doing studies on lean body mass and walking studies and dietary intake in the elderly. So there's that pattern you can work with. I don't know. It's hard for me to say.
Okay.
I don't know.
No, that's great.
Is
That's
that enough?
great. And here's another good one. What is your day-to-day job like?
What is my day-to-day job?
What does your day look like?
Yeah. So the primary part of my day is consumed by being a clinician, working one-on-one with patients. So individuals will come in to see me one-on-one. They will come in. I will go and see them during their chemotherapy infusion. I will go and see them before or after their radiation therapy, and I'm working with them to deal with those nutrition impact symptoms, loss of appetite, nausea, doing a tube feeding teaching, making sure that they're not having the weight loss, and then also doing education like this. I also like to do one-on-one teaching about what next. I've been diagnosed with cancer, now what? I'm doing fine during treatment, but I want to be healthier later on. I love those, survivorship consults.
Yeah.
So the majority of my day is taken up. I'm working in the clinic and then doing some community outreach and some education like this.
Great, thank you. Let's take two more questions and then we'll go ahead and wrap up and remind people about that evaluation one more time. Do cancer patients at your facility automatically have a dietitian to help prevent great weight loss from the beginning of their treatment?
Yeah, I wish.
Yeah.
We just don't have the capacity to see everybody. It would be the ideal situation if every single one of our cancer patients could have an initial visit just to get some of the healthy eating survivorship guidelines for those individuals that may not be at high risk. For the majority of our high risk patients that are really going to have unintentional weight loss during treatment, the oral head and neck cancer patients, the GI patients, lung cancer patients, these are some of our high risk patients. Those ones are almost automatically going to be seen. So not everybody can see. We just don't have enough dietitians yet.
Sure.
Yeah.
All right. And then last question, how do you handle questions from patients about unproven dietary regimens for the treatment and prevention of cancer? Vitamin D, vitamin C, no sugar, these sorts of things. Great question.
Yeah, that's a great question. So I always try to base it on evidence and give them resources where they can go and maybe debunk some of the myths by showing them and talking to them about where the evidence is and where it's lacking. I get a lot of those questions and I try to be realistic. That's that building that trust part of it. You can have the medical team, nurses or physicians may not ask the right questions and they may not find out that a patient is taking 20 different dietary supplements because they want to do something in addition to their cancer treatment. But if you build trust and I go in and I ask them, I'm not going to try and take them away. I want to find out what you can use during treatment and what might be beneficial in terms of supplements, vitamin and mineral supplements and herbal supplements, and then make sure that you're not taking anything that's going to be detrimental or contraindicated for that treatment. So creating a rapport and working with that individual, giving them really good evidence. You cannot prevent it once they're in their own home. You can only give material, you can only give evidence-based information to guide them, and then they're going to have to take that and do what they will with it. You can't be there every moment.
All right. Great answer. So we want to say thank you. We want to say thank you to you, Jennifer.
Thank you.
We want to thank the North Carolina General Assembly for their generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to thank our team, Mary King, Veneranda Obore, and John Powell, for all the hard work they do for this and every one of our lectures. Hey, if you need to find us, unccn@unc.edu. There's our phone number, 919-445-1000.